Welcome back to this session in pharmacology, where we've looked previously at what we actually mean by a drug, how drugs are named, and various ways of classifying them. We also looked at legal and ethical controls around the use of drugs. Now let's actually look in depth at those two key principles that we said are parallels even when you're studying Western pharmacy and complementary medicines, this idea of a pharmacotherapy. The underlying principle here is that there is a relationship, a mathematical relationship between the dose of the drug and its use, its effect in the patient in treating that disorder that it is therapeutic for. Okay, so in pharmacology we study two aspects of this key fundamental principle. We look first of all at the pharmacodynamics, so the dose gives a response, and that response is a pharmacodynamic response. It's how the drug affects the body and what the drug actually does to the body. So pharmacodynamics will apply all of your studies in physiology and biochemistry, because you're looking at what that drug is doing at certain effector structures in the body. And this we'll call its mechanism of action. It's the effect that it has at that receptor, and largely explains some of the adverse reactions, especially those type A ADR, those ones that can be predicted because of its pharmacodynamics. Now we'll see that the dose that you will use for a particular drug is also dependent on various pharmacokinetic parameters that are going on in the body, and pharmacokinetics, put basically, is what the body is doing to the drug. So compare that with pharmacodynamics. Dynamic meaning moving, what the drug is directly doing to the body, and kinetics is what the body is doing directly to the drug. So the drug is altered as it moves through various processes that we will look at in some detail. We'll look at absorption, distribution, metabolism, and excretion effects. But first of all, there is another important phase that we can't just quite leave yet, because we've been talking about the active ingredient in a medication being the drug, but it's only part of the formulation. And so there is a key phase that occurs just before the pharmacodynamic and pharmacokinetic phases and determines some of the parameters of both of those phases, and this phase is called the pharmaceutical phase. In this phase, that formulation of the drug, whichever form it was taken in and whatever dosage, it has to dissolve. It has to then make its way through absorptive processes into the body. So we need to look at how a drug is administered to the body and look at this pharmaceutical phase. We'll consider it again later when we go on and look at how formulations and dosages of drugs are mathematically determined. But here's the pharmacokinetic phase that kicks in straight away the moment absorption takes place. The drug is available for absorption after that administration by whatever route. It is then distributed to the body. Because it's been absorbed, it's now available for distribution to various body tissues and organs. Thereby, because of administration, absorption, and distribution, the drug is now available for action. And remember, action is pharmacodynamics. So once all those other phases have occurred, first of all, the very important pharmaceutical phase where the body starts to disintegrate that particular dosage and formulation by that route by which it was administered. Now we have it at the site of action because of absorption and distribution through the body. So this is where the drug actually meets its molecular target, its effector, where we said it has that dose response. However, dose is also affected by the body now starting to remove at various stages during distribution, during absorption, and during pharmacodynamics, taking some of that substance via various organs. We'll see particularly the liver and kidney, and starting to excrete it. So that's going to affect the dosage that can be achieved in the tissues where you want to have that desired effect. So we mustn't ignore that very important pharmaceutical phase, and in your research into complementary medicines, a lot of the research will go into looking at the correct formulation to get that disintegration of the substance down and into the tissues where it can be absorbed and distributed appropriately to have its action at its site. But we've used a pharmaceutical example here where the majority of medications are taken in some sort of solid form. We've shown a tablet, though there are other formulations other than tablet form. So that tablet had to be broken down into granules and then into much smaller particles. It was still a suspension in your body fluids. In this particular case, that chyme, the fluid in the gastrointestinal tract. And so that's the pharmaceutical phase. Before anything else happens on that drug, that's the first and most important part, where the chemistry of that drug and the chemistry of the chyme are also important considerations. But now at long last, we can absorb some of that drug, and mostly that will occur at the small intestine. For certain drugs, we will look at some differences to that. They may be absorbed through the lining of the buccal mucosa. There may be some absorption through the stomach, but largely for most drugs it will be at the small intestine that the next phase, the pharmacokinetic phase, begins. So we will look also at some of the things that can speed up the dissolution phase. We talked about the chemistry of the formulation and the chemistry of the drug being very important here, and you may do a lot of those studies on complementary medicines, looking at getting a more rapid dissolution phase so that it can be absorbed through the skin, small intestine, and so on. So we want to get that more rapid drug presentation at the membranes of the body, whatever that membrane might be. So as a general rule, liquids tend to be absorbed much faster than suspensions, which are absorbed much faster than powders. So in pharmaceutical substances, most of them tend to be powders, then compressed down to a tablet, or perhaps in a capsule, or in some sort of coating, an enteric coating, which will prevent damage by stomach acid, hydrochloric acid. But in complementary medicine, those therapeutic substances might be taken more as liquids or suspensions in teas, and studies on how to get the best formulation for the best absorption from these other formulations. So capsules would be absorbed much faster than tablets, and the idea with enteric coating of tablets is to delay that pharmaceutical phase, or as we said, to prevent some sort of chemical alteration on that substance. Where EC is enteric coated tablets. Okay, so now kicks in the pharmacodynamic stage, because the moment you start getting some of that drug absorbed, it will start to have potency in the tissues. Note, we may not have a dose that might be effective as yet, but we'll have a potent dose being absorbed, so the pharmacodynamic phase will start, where we get an interaction between the drug and its actual molecular target, its mechanism of action, or MOFA, M of A. So we said pharmacodynamics, what the drug does directly to the body. What we would ideally like with any drug, be it a complementary medicine or a Western pharmaceutical medicine, is for that drug to show a specific action at a specific molecular binding site in the body, but this is an ideal. This one target, one site of action, one effect ideology. What is more realistic is that you can get a selective action. There may be certain categories to your target, and it may show selective actions at only a few of those categories of the main target. So to understand this concept, we've got to look in some detail at molecular targets, and you'll see that we are studying proteins in the body, why we needed you to have a background in biochemistry and in physiology for you to understand that drugs work at protein carriers. Enzymes, which you saw, are proteins. Ion channels, these may be in the membrane of cells and perhaps other organelles in the body, but that these ion channels are proteins. And then last of all, one of the major molecular targets for drugs, receptors in the body, and largely these receptors will be at the cell membrane and will be proteins, glycoproteins, lipoproteins, but largely protein. Now these receptors may not be at the cell membrane, they might be once again within the cells of the body, and you have enough physiology background to be able to then understand this concept of proteins, other major molecular targets for drugs. So the concept here is that that drug, whether it was in a pharmaceutical preparation or a complementary medicine, binds to these target molecules. It might inhibit their natural action. That drug might increase the natural action. It might alter the biochemistry, or it might alter the cell or the tissue or the body in interacting with that target. So even homeopathy, though it may work not by a mechanism of action, a mechanistic way, it might be a quantum change, something that is in zero position, turned off, and with the homeopathy gets switched to the on position. So very quantum in its approach, it still then alters the way the body's cells, tissues, or biochemical targets then respond. Let's look at each of these proteins in some deeper detail so that you can go back and do some preview if you need to. These carriers are the proteins through which ions and small molecules move into the cells or perhaps into organelles. It's this idea that the membrane-bound organelles have a lipid membrane, or the cell membrane itself is a lipid barrier, and it defines extracellular fluid from intracellular fluid. So therefore these ions and small molecules that are soluble in water need a carrier channel to move through, and these are proteins. So glucose is one such small molecule that, because of its water solubility, needs a glucose channel, a protein. We called it GLUT and studied GLUT4 in skeletal muscles. But sodium ions, calcium ions, these need to be transported from outside to inside or the other way, given that sodium is our major extracellular electrolyte, but we'll look at that channel in a little bit more detail. But it's this concept that it's a protein channel. Some of these carriers, these transporters, might be involved in the uptake of chemicals which are neurotransmitters, or perhaps the metabolites, but ones where it's actively the neurotransmitter that is uptaken by a nerve cell. Noradrenaline, abbreviated to NA, 5-hydroxytryptamine, a neurotransmitter, abbreviated to 5-HT, and glutamate, which you'll recognize as an amino acid. That's also, as we'll see when we study excitatory and inhibitory substances in the central nervous system, glutamate is itself a neurotransmitter, and it's taken back into a nerve via a protein channel. And so we can have drugs that bind to that protein and alter its actions, either inhibiting the movement of the natural substance, perhaps enhancing it. Right? helping that substance enter its target cell and thereby improve physiology, act as a therapeutic substances. And some drugs may just inhibit the movement of substances in, and then there may be drugs that keep a channel permanently open and thereby have an action in the body. So another major class of targets for drugs, enzymes. We saw that enzymes are proteins. You know that they are the biological catalysts of biochemical reactions. Very few of them are spontaneous in the body, and most need that catalyst to make them happen in a speedy fashion that's under homeostatic control. So drugs could inhibit the action of a specific enzyme, altering a particular physiological response. Drugs might be so similar to the actual endogenous substrate, the inside chemical, endogenous substance. So this drug, the exogenous substance, combines with the drug, the enzyme, and so the drug might then stop the substrate binding. You get an accumulation of the substrate, or an abnormal use of that substrate in the body as a response to this drug. And the other reason why enzymes are also very important as targets for drugs, as we'll see later, enzymes might actually activate a prodrug into the actual drug in the body. So the substance that's in the formulation and absorbed and whose chemistry you need to know about at the pharmaceutical phase may not be the actual substance that is then distributed to the body tissues to have the pharmacodynamic action. It might be a metabolite of that prodrug. Now we'll look at calcium channel blockers as important examples and their indications in the body in disorders such as hypertension, when we look at transporters as important targets for drugs. There will be a whole range of enzymes that are important targets for drugs, and drugs that have their mechanism of action at an enzyme. At this early stage, before you've had a look at the drugs affecting the body systems, we're going to choose one particular enzyme, cyclooxygenase, abbreviated to COX. And we've chosen this particular enzyme because you've studied it at a biochemical and a physiological level of knowledge. See, this COX enzyme is the important enzyme in cell membranes, where under normal homeostasis, if there's a pathological insult, so something that impacts on that membrane like a bacterium, that speeds up the production of arachidonic acid. Normally any arachidonic acid that is made is readily converted back into non-physiologically active forms of lipids in that membrane. It's only when there's an insult that large amounts of that arachidonic acid remain and build up because of this enzyme, cyclooxygenase, which then converts that arachidonic acid into other chemicals. So more and more and more of this arachidonic acid can then be made in response to that bacterial infection or other insult. So cyclooxygenase being a very important enzyme then, mediating inflammation, where you know pain and fever are a couple of the key signs and symptoms of an inflammation. Those physiological changes being mediated then by the prostaglandins that were directly made from arachidonic acid via the catalytic actions of that COX, an enzyme, cyclooxygenase. So what we're looking at here is drugs that target cyclooxygenase, and they will be called COX inhibitors, or in other words, a cyclooxygenase inhibitor. Drugs such as paracetamol are important COX inhibitors, and we'll also see that aspirin and other non-steroidal anti-inflammatories are COX inhibitors. That's how they have their mechanism of action. So now, if the person has a bacterial infection and there is the potential for pain and fever, we can block those symptoms by blocking cyclooxygenase, a drug that switches that enzyme off. And we'll look at how paracetamol does that reversibly, and how aspirin does it irreversibly, that each drug, though it may target the same chemical in the body, may do so in different ways. But with both aspirin and paracetamol, that they will reduce pain, they are analgesic, and they will reduce fever, they are antipyretic. But as we said, aspirin is anti-inflammatory, whereas paracetamol, in the doses that are used in the body, is not. Another important protein then, we've looked at transporters, such as the protein that transports calcium into cells. And we've looked at enzymes, such as this cyclooxygenase enzyme that's present in most of the body tissues, anywhere where membranes can become damaged and anywhere where an inflammatory process can be set up. Then in certain other tissues of the body, there might be ion channels that are more to do with regulating the flow of ions in and out. So we want to maintain a particular gradient, a concentration of that ion inside the cell and outside the cell. So some of the very important electrically active tissues of the body might have these important ion channels for sodium, where you want to control its concentrations. Sodium is your most important extracellular electrolyte, and these electrically active tissues like your heart muscle, nerves, and other muscles in the body will pump the sodium outside the cell so that there's actually a higher gradient outside the cell than inside. So through other ions in the body, it might be a different electrochemical gradient comparing inside to outside. But being an ion channel, we now have drugs that could target this channel, might block that channel. So here we have a diagram showing an ion channel, and we've got the ion channel in the open configuration in that membrane. Then with the drug, the red shaped molecule, it blocks the ion channel and thereby stops the transport of that substance into the cell. But last of all, though those other ones are important, our normal transporters for just regular ions needed by the cell, and those particular gated ion channels that actually maintain a gradient of that ion, and then enzymes. Really important proteins in the body, major targets of drugs, but as we will see, these receptors in the body, one of the most important molecular targets for drugs. So these are chemicals either in the membrane of the cell's membrane or in the organelles and their membranes. These are proteins to do with chemical signaling, and sometimes these chemical signals can control the body's, that tissue's metabolic processes, or it might control DNA or transcription processes. But there's some important chemical signal that is mediated via that receptor. So the normal endogenous substance, an endogenous molecule, would bind to that receptor and have a physiological action. And now we have an exogenous substance, a drug that binds and produces a pharmacological action. And there is usually some sort of structural specificity to that molecule. Now remember that this drug might block at that receptor or could activate at that receptor, and we'll look in more detail later about those two actions. And we've already hinted at with enzymes that something might inhibit, it might also activate. even with our ion channels and our transporter channels, substances that might block the channel or keep it open, that there's always other possibilities, and that it might be a reversible change or it might be an irreversible one. Here we've used as our example a substance that binds to a receptor that's in the cell membrane. It's a non-steroidal hormone. Just say a growth hormone, insulin. That chemical does not actually enter the cell, that normal endogenous hormone. It just merely binds to a particular site on a cell membrane protein. So now we have a drug that shows some sort of structural specificity. It may not be the same chemical class as your endogenous substance, but there's some shape that enables it to also bind to that receptor or a related site. Okay, that kick-starts a response through the body tissues. We're going to talk about this one in more detail shortly, where you get a second messenger activated in the cell of the body only when the endogenous substance or a specific exogenous drug binds to the receptor, and that second messenger activates a whole variety of proteins in the cell and then leads to one normal cytosol component being converted to an active product that then sets off, say, smooth muscle contraction in that cell. So an agonist would be something that activated the receptor, and an antagonist would be a drug that bound but then blocked the action of the normal non-steroidal hormone. So now our drug is taking the place of the first messenger in the body, but either enhancing that first messenger's effects or blocking it. As we said, these receptors, the major site where drugs work, so we're going to classify them even further. These receptors in the body are of 4 basic types. We will see that the G protein coupled receptors that use a second messenger, like that cyclic AMP, CAMP from the previous diagram, is one of the major receptor types. If receptors are one of the major proteins by which drugs work, then GPCRs, G protein coupled receptors, are one of the major receptor types where drugs work. It's been estimated that 1/3 of all marketed drugs, which would include complementary medicines, would target these GPCR. But some other ones. There are ligand-gated ion channels. So now we're not talking about the ion channel that directly transports the substance and the drug working at that protein. It's got another site where a ligand binds. Ligand is just a term that means to bind, and it gates that channel. It can either shut it or open the channel, and so we've now got the drug to target the ligand site. Some examples of some ligand-gated ion channels in your body are the acetylcholine receptor. This would be found then, of course, in nerve tissue and also in various smooth muscle tissue throughout the body. And there are various different types of this receptor, and you have studied this in physiology. So just to remind you of one of those types, there is the nicotinic acetylcholine receptor, and it's seen to be this ligand-gated ion channel type. Now, of course, there's other different types of acetylcholine receptors, and they may not be this ligand-gated ion channel. They may be one of the other types of receptors. Similarly, there's a neurotransmitter in the body called GABA, gamma-amino butyric acid. Note that name. We're going to talk about it in some detail when we look at those drugs that we were talking about that treat anxiety. Now, once again, there's a variety of different receptors, and each of them will be, as proteins, function completely differently. But this GABA A receptor that we're going to be very interested in, where these anxiolytic drugs are working, located on the cell membrane, and there's this ligand-gated ion channel. And this will be important when we see that the drugs that bind don't actually bind to the site where the neurotransmitter GABA attaches. They attach at a different site that modifies the actual active site for the neurotransmitter. So GABA-A is this ligand-gated ion channel type of receptor. So GPCRs, as we said, the most important. But another type are these kinase-linked receptors. You saw that activation of kinase enzymes was important using GPCR where there was a second messenger. But others, we've used as our example the receptor for insulin hormone, a non-steroidal hormone in the body, is a kinase-linked receptor. Not using a second messenger, just the action of the insulin at its hormone kickstarts a kinase reaction in that particular membrane and in the cytosol. And last of all, another major family of receptors are the so-called nuclear receptors, and these are the receptors that are important for the steroid hormones. The actual chemical to which the steroid hormone is binding is actually in the cytosol though. But the complex, the steroid hormone itself, your endogenous substance, and its target protein move into the nucleus. So that's why they're called nuclear receptors, because the activated receptor is active in the nucleus. So we've mentioned hydrocortisone as one of your natural steroid hormones that you studied when you studied the adrenal glands, and we're saying to you that now an exogenous substance, a formulation that might be metabolized down to hydrocortisone in the body but taken as a drug, will also work at that same protein receptor in the cytosol, moving into the nucleus to then affect transcription of the DNA. So here's the G protein coupled receptor. As we said, one of the major receptors, and probably 1/3 of all drugs that work at receptors are working at GPCR, and these were the ones where a second messenger was involved. In your text, it particularly talks about activation of the second messenger cyclical AMP from ATP only when a drug, an exogenous substance, or the endogenous chemical binds to the receptor, changes a G protein. Called a G protein simply because it involves guanosine triphosphate in changing its protein shape, so that it then activates the active site of another enzyme, a cyclase, that takes adenosine triphosphate and makes it a cyclic molecule, so adenylate cyclase, turning ATP into cyclical AMP. And cyclical AMP, CAMP, activates many protein kinases, and we saw that that activation of these endogenous proteins in the cell then is actually what mediates the cell action, in this case a change in smooth muscle, perhaps leading to relaxation only when that endogenous chemical was made in the body, perhaps a hormone, or where a drug that acts at the same receptor kickstarts that process via the second messenger. But so you don't think that cyclical AMP is the only second messenger, we've mentioned a couple of other ones, and one that's got a delightful name is DAG, and diacylglycerol is the secondary messenger, but DAG, what a gorgeous name. So similarly, via some other G protein coupled receptor now, only when an endogenous substance with the right shape or a drug with a similar shape binds do you get a change in that receptor protein. The normal endogenous substance would kickstart activation of that G protein, the one that uses guanosine triphosphate to change the active site shape of another membrane protein, thereby activating a metabolite in the cell to diacylglycerol, activating a whole variety of other protein kinases and leading to other changes in that tissue. In this particular tissue, it's a glandular tissue where you'd then get increased secretions, only if that endogenous chemical bound. Well, now we've got a drug that attaches to that same receptor and could either increase secretions or block the production of those secretions because it acts at that G protein coupled receptor. Now, it's not always an enzyme that's activated, as you can see with some of these other metabolites of diacylglycerol. That might lead to release of calcium stores in that cell, and it might be the calcium stores that then lead to a smooth muscle change. And here, generally, if it wasn't via kinases, if it was via release of calcium, as you would know from your studies in physiology, that would lead to a smooth muscle contraction. So then nuclear receptors, we saw that this was very important for the mechanism of action of our endogenous steroid hormones, and so it's an important site by which steroid drugs work at a nuclear receptor, that only when that drug is present in a systemic circulation or that hormone is being manufactured and released into the systemic circulation do you get that an exogenous drug or that endogenous chemical binding to its receptor, the combination of the two then moving into the nucleus and then affecting the transcription of a whole variety of proteins. So those proteins might then mediate an inflammatory response or an immune response activating B cells or cytotoxic T cells. Similar to studies in physiology where the endocrine system tended to have control over long-term actions in the body, similarly these drugs that work at nuclear receptors have long-term courses of action. So here we've shown hydrocortisone. We use that as the example of our endogenous hormone, but we said you might also take that as a drug or take a prodrug that was metabolized down to hydrocortisone so that the drug is mediating at that protein receptor and affecting its target, the gene transcription and protein translation in that cell. Here's another exogenous substance we've used as another example. It could be a steroid drug such as beclomethasone, which is inhaled in certain people who have asthma, and its mechanism of action will be at the same physiological targets as the normal endogenous hormone hydrocortisone. So that beclomethasone will be having its actions by binding to its receptor, the hormone drug, and the receptor moving into the nucleus, modulating proteins and affecting anti-inflammatory responses and so on.